What's up, guys? It's Dr. Tim Jackson. Welcome to another episode of the Boss Body Podcast. Today, I have with me a very special guest, Dr. Gene Sambataro, one of the first biological dentists in the United States.
While I make every effort to broadcast correct information, I'm also still learning. I will double check all my facts, but realize that healthcare is a constantly changing science and art. One doctor or healthcare provider may have a different way of doing things from another. I welcome any comments, suggestions, or correction of errors. I take no money from supplement or device companies. By listening to this podcast or reading this blog, you agree not to use this podcast or blog as medical advice or to treat any medical condition in either yourself or others, including but not limited to patients that you are treating. Consult your healthcare provider for any medical issues that you may be having. This entire disclaimer also applies to any guests or contributors to the podcast or the website. Under no circumstances shall any guests or contributors to the podcast or blog or any employees, associates, or affiliates of the Boss Body podcast be responsible for damages arising from use of the podcast or the blog. This blog or podcast should not be used in any legal capacity whatsoever, including but not limited to establishing the standard of care in a legal sense or as a basis for expert witness testimony. No guarantee is given regarding the accuracy of any statements or opinions made on the podcast or the blog.
Welcome to the show, Dr. Sam.
Oh, it's great to be here, Tim. Thanks for the invitation. Thanks for all you do. It's awesome to have like-minded people now out spreading the word. As you said, I probably wasn't the first, but I may be one of the last of the early on. Most of my mentors have passed on, like Dr. Hal Huggins, who was, definitely the pioneer in the 70s. So thank you for what you're doing, because it's been a long time for us to try and get the word out. And there were years when we just couldn't even talk about these things. So thank you so much.
Yeah, well, thank you, because I know a lot of dentists were persecuted. From what I'm told, if you remove mercury amalgams because you say that they're dangerous, it's a neurotoxin, they can yank your license. But if you say I'm doing it because it's for aesthetic reasons, they'll leave you alone.
Yes. In addition, if you take them out, you have to then put it in a hazardous waste receptacle outside the mouth, but it was safe in the mouth. And these are regulations by the American Dental Association. So, they're talking out of both sides of the mouth. And then in the 90s, when we talked about it, we couldn't even mention it to a patient. And then finally, there was a judge, actually, I think it was in Maryland or Baltimore, that said he lifted that gag rule, that you can now inform patients. Because it is really, basically, as you know, Tim, it's about informed consent. And I think that's the big thing that we're dealing with now, obviously with Robert Kennedy Jr. and Maha, that we just need to inform people, and then they can make a decision. People are intelligent, but don't tell them lies. Don't mislead them or not tell them what you know. I always mention to my patients, look, this is just my knowledge, my experience. I don't know it all, but I just want to share that with you so that then you can make a decision, informed decision, an educated decision.
Absolutely. And I heard it very well put last year sometime. Someone said, informed consent, it's not just saying yes to the therapy or treatment, it's saying no to all the alternatives.
That's a very good way of putting it, because a lot of times they're not giving that option. They're given one option. This is it. And if you don't follow me, you're no longer a patient of mine. No.
Yeah. So talk to us, because you went to dental school. Where'd you go? University of Maryland?
University of Maryland, graduated in 1980, did a hospital residency for a year, went into as an associate in a private practice in 1982, and realized at that point in time I didn't want to work for someone else. So I started my own practice, and in 1986, a very dear friend of mine, one of my best friends from elementary school and high school, was diagnosed with a stage 4 melanoma, and they gave him 3 to 6 months to live. He should go home and get his affairs in order. He's now, in this day, right today, is still alive after given a fatal diagnosis. But the interesting thing for me is that he went to a holistic center in, I think it was San Diego. It's called a Livingston Wheeler. I don't think it exists anymore, but the first thing they said to him is to open your mouth and said, you got to get rid of all that metal out of your mouth before we can start treatment because we don't feel that the treatment's going to be as effective. Well, when he told me that, I was like blown away. And I'm like, what does that have to do with anything? I mean, I'm right out of school. I know it all. They told me it was perfectly safe. So, as you know, Tim, sometimes the universe brings you this information. You can either ignore it or pursue it to see if it's true for you anyway. So my truth was I found this book. I don't even remember how. It was called It's All in Your Head by Dr. Hal Huggins. I read that book and I remember saying to my wife, who's been my dental hygienist for over 40 years. We're still working together. We're still married. So I said, we're poisoning our patients. We got to do something. So I remember we were on a plane. I'm reading this book and we landed. I got right on the phone. I called this guy, Hal Huggins in Colorado Springs. I said, I need to come out and study with you. I need to learn this stuff. So that was the beginning of the large rabbit hole as we all have gone down. And from that point, you can't unknow. Right. And in 1987, that was 1986, 87, when we stopped doing all mercury, I called my dental supplier and said, please, I don't want you to give it to somebody else. I want you to just dispose of it, but get all the mercury out of my office. And Tim, at that time, we were actually mixing it by hand. So I had these bottles of liquid mercury and then these pellets that had silver, copper, tin, and zinc in it. And we used an amalgamator to mix the two together, created this soft putty, and put it in the patient's teeth. And I said, we're not doing that anymore. So, and then part of that with Hal Huggins, as I learned from his protocols, that not just stop doing it, but we need to take these out, and patients want them out. We got to do them safely, which is still a concern because a lot of dentists will say, oh, I have no problem. We can take them out for you. And I end up with those patients because they come in and they say, something didn't seem right because I asked my dentist, is it okay just to take them out or do we need, like oxygen or dental dam? Oh, no, it's perfectly safe. So that's been an ongoing thing, and it's still existing today, even though in Europe it's now been banned, and it will shortly be in this country. And it looks like also fluoride. So, thanks to Robert Kennedy Jr. and Dale Bigtree and a lot of the other names out there who've been fighting this anti-fluoride. And one of the first person I want to give credit to is David Kennedy. So if you really want to know about the fluoride issue, go to, on the web and look up David Kennedy. He was another mentor of mine. So great guy. And I think he's actually still spreading the word.
So fluoride, let's talk about that. I'll tell you a quick story. A colleague of mine in Pennsylvania, about 45 minutes outside of Philadelphia, she's occupational therapist, but she's in the biomedical world because her son has Asperger's. But her daughter had a dentist come to their elementary school when she was like 7, maybe 8. And, he's talking about the importance of fluoride. Well, little Victoria, being the smart young girl she is, raised her hand and said, don't you know that, fluoride is harmful for the thyroid and it calcifies the pineal gland? And the dentist goes, who told you that? And she said, my dentist. And he goes, I think you need a new dentist. And she said, I think you need a new dental school.
Yeah.
So,
I mean, it's somewhat easy for me to understand because I came from that background also. So it was challenging to transition. And I think, Tim, also, there are certain people you can give all the information and they just won't accept it. I don't know what it is. One of my mentors said it's related to your higher consciousness. You're more evolved. So I don't want to say we're better than other people, but why do we accept these things and others just refuse it no matter what? So, and there's plenty of evidence. And they say, oh, there's no evidence. Yes, there is. Go and read and look at it. But you only want to read what's in the American Journal of Dentistry, then you're not going to get the truth.
right. I mean, one of the I don't know her name, but she was a former editor of the New England Journal of Medicine. And after she left, she couldn't say it while she was there. She said, the medical journals, they're all just advertisements for the pharmaceutical companies.
That's who supports them. That's who supports the medical schools. So you're indoctrinated to those belief systems. And yeah, and when you talk about fluoride, yeah, they keep saying it's like the number one best public service of of all health things that have ever been done. Like it's poison. And and you know the sad part about it, because we talk about informed consent, I never voted to have it in my water. No one
Right.
asked me if I wanted it in my water. They just put it in your water. I mean, so you're talking about mandates and censorship and things like that. Where's the freedom of asking the people? Because I would
Right.
have said, well, initially I probably would have said, oh, that's good. It's going to prevent cavities. So, and just and give you a story as you just did. I grew up on fluoridated water, and I had cavities in almost every tooth. My children only grew up on well water and had no cavities. So, I mean, I know that's only n equals 1 or 2, but it's evidence, and I've seen this over the 45 years I've been in practice. I see patients who have been on fluoride and they have cavities.
Yeah.
Others who have good, healthy diets, as Weston Price would have did teach about. That's where you see the difference. So, and of course, it's also about using things like Listerine and Colgate, all these fluoridated products as being the answer. Well, that's just as you just said, it's all supporting those companies or those large corporations are not. And so people, they watch mainstream media and they believe that's what they need. So not knowing that it could possibly be toxic, and then as you said, they go to their dentist and they'll say, "Oh, that's crazy. I don't know where you saw that. Just listen to the science." They're not looking at the science. And I know,
Right.
Tim, you're like I am. We can't get enough information. We're constantly reading. We're constantly educating ourselves. I want to know what the truth is, and I want to know what both sides are, because then I can make a decision. And then sometimes it comes down not to the science, but common sense. Like what makes sense?
Yeah. Right.
Yeah.
And like you said, n equals one. A lot of scientists will say, oh, you've got to have, 44,000 subjects in a study. They forget the entire point of a study is to improve patient outcomes. So if I come to you as a patient and I'm like, okay, here's what worked for me. And you're like, no, I have a paper right here that says that doesn't work. And I'm like, well, no, I mean, you can see my x-rays before and after it changed. It blows my mind. Like, most discoveries that moved the medical profession forward were scientific serendipity. Penicillin. There was
Right.
not a randomized controlled trial. They didn't exist at the time. It was scientific serendipity.
Right. And as many of the studies now, I mean, we know, not to get off on a tangent into the vaccine industry, but we know most of those studies were flawed. I mean, they had samples of less than 100.
Yeah.
So how does that even qualify?
Not to mention they didn't have a control group,
Right.
placebo
No
group.
control group. And the studies were like, what, 3 to 4 days? It's like, yeah, it's insane. But yeah, so
That's that's not a
it's
study. That's a
crazy.
sleepover.
Right. That's right. Like what?
Yeah.
Yeah. So what happened 3 to 4 days after the vaccine? Not what happened 6 months, 1 year, 6 years.
Right. Well, I know that RFK Jr., Del Bigtree, and some other people met with Anthony Fauci and other scientists at NIH, and they admitted they don't do controlled trials because they don't want to have a placebo group, because that would mean a group not getting it. They started to do one, and they used saline as the sugar pill, and none of those kids were getting sick. A lot of people in the treatment group getting the vaccine were getting sick and ill. And so they stopped the trial. But that's not science. That's dogma. You have to report everything you find.
Well, it's interesting how they'll say we don't want to give it to a control group, or not give it to a control group because it's not fair to those children. But you're going to inject kids without complete informed consent, like, and
Right.
and then the parent suffers, and then they claim that the parents don't remember what their child was like before the
Right.
vaccine. Sure, they do. Every parent, being a parent, I knew every day if there was something going on, and even today, my children are older. I know if something's not right.
Right.
Uh, It's crazy.
And that's the thing, a colleague of mine, who's a cardiologist, Dr. Jack Wolfson, the paleocardiologist, he says that, you better listen to those mommy bloggers because they're pretty dang smart. Parents are pretty busy, especially parents of young kids. Several million parents didn't wake up and say, it would be a great day to come up with a conspiracy that a jab, harmed my child, my son or my daughter.
Right. And, and then spreading that into the field of dentistry with the, toxic substance called mercury, which is the most non-radioactive toxic material on Earth, which has been taken out of things like mercurochrome, taken out of thermometers, because I certainly remember using those things as a child. It's illegal, been taken out there, but it's still okay to put it into a human biological system, of which you're being exposed 24/7 and exponentially exposed if you're drinking anything above room temperature, which is a unique property of mercury, unlike other elements, is that it vaporizes based on the temperature. So the higher the temperature, the more vapor comes off. And I always tell my patients, look, think about this. If I put in front of you a cup of silver and another cup of mercury, and we came back a week later, you'd still have the same volume of silver, but most of the mercury would be gone. I mean, it's just into the atmosphere. So
Right. And talk about biogalvanism, basically creating electricity in the mouth.
well, Tim, it's interesting because we learned about galvanism freshman year in dental school. They just explained what it was when you took two different metals and they created an electric current, and that was it. Never talked about the potential effects of it. So when you start to mix different metals, well, first of all, an amalgam, they call them silver fillings, but it should be technically called mercury fillings because 50% of the composition in a chemical composition would always be called by what has the highest ratio. So you have mercury, copper, tin, zinc, and silver. And then you go and you take a nickel-based crown and put it over top of it. Or you put a gold crown above it, so now it's occluding the gold on the mercury amalgam, creating, as you just said, galvanism. That's an electric current that disturbs the normal flow of energy from the body, certainly from the head down, and it obviously is going to affect the brain. And then if you talk about the meridian system that runs through every tooth, where's the acceptance that that's okay? That's a disruption in the energy field or a blockage or interference, whatever you want to call it. And now, worse than ever, we have all these EMFs that we're getting bombarded with. And I remember back in the 1990s when I studied with Paracelsus, and I remember them talking about if you've got metal in your mouth, you are basically a walking antenna.
Mm-hmm.
Of course, now we have, and we didn't have 5G then. So,
Right.
So what are we dealing with now? So people are putting this phone up to their face where there's an amalgam right there. Yep. How is that disturbing it? And I still see patients. Tim, I said to my staff about maybe maybe a little more than that years ago, I said, you know what? We need to look at how else we can help patients because our main focus has been taking mercury out. It's not going to be around in 5 years. I was wrong. It's still here. I still see patients coming in with amalgam recently placed or they've been in their mouth for 20, 30, 40 years. But people are waking up.
And so I know, we talked before we started recording about zirconium, there's ceramic implants, but for fillings, what are the options?
For fillings, well, you basically have composite, which are a resin-based material. In our office, I have basically taken and made a library of all those materials that do not have BPA in it, so I know they're less toxic. And then we have entered into a library with a technology called Zyto. So we're checking each of our patients for which material is going to be the least reactive, and maybe even not reactive. It's still a foreign material, so it's still a challenge. So they're putting something foreign in there. And as Dr. Huggins taught me, he says, don't go from the fire to the firing pan, because composites are plastic. So, and I remember, and I know you probably remember the movie The Graduate, right? And he said to the young graduate, you should always think about investing in plastic. And that was in, I think that movie was supposed to be like in the 60s or early 70s. And look where we are now, plastics everywhere. So do we want to put those in the mouth? Well, when I first started learning about the dangers of mercury, composites were really the only other option. Now we have things like zirconia, emax. So they're all ceramic. Most of those are non-reactive. Can I say they're 100% safe for every individual? I can't. But we can at least test them on the Zyto. And if I have someone who has a history of allergies or mast cell activation, I'm going to do a blood test and check that for every dental material on the market. And when we do that, I compare it to the Zyto and to that test, and I can find out like what's going to be the ideal product for that patient. So it's somewhat limited, but it's better than where we were.
And which of those did you say are BPA free?
Well, zirconia definitely is. So, but then there's composites like Admira. Trying to think of all the different ones we use, but I looked at the material data sheet to figure out which one exactly what was in there and what was BPA free, and from that, then put that into the library for Zyto. So one, we know it's not as toxic as some of the others, and then does it actually react? Because even some of those materials are highly reactive to some of our patients. And as you know, Tim, we're in a toxic world now. So people are so much more sensitive than they were before. And our buckets are very full. So just one toxic substance placed into that barrel can push them over the edge. So so that's the challenge. We don't have patients that are super resilient as we did 20, 30 years ago.
Yeah. And, like you were saying, so dentists are going to read the dental journals, but, if you just go to PubMed and type in mercury and neuronal health, mercury and central nervous system, I mean, you can see hundreds and hundreds of studies showing it's a known neurotoxin. It lowers IQ. It kills neuron in vitro. So why is it still an option?
Right. And if you're swallowing it, we know from many years ago that it will then distribute in other parts of the body. It can make it the bacteria antibiotic resistant. Of course, the early studies were done on sheep where they placed the amalgam within 24 hours after they found the mercury in the brains and kidneys of the sheep. But, that was years ago. So where have we come from? I mean, it's been a fight. And I want to certainly commend Charlie Brown, Consumers for Choice. He has been fighting this globally to get rid of the mercury toxicity in the entire world. He's had great success in Europe and still fighting it. We're ahead in the U.S., but we're not there yet.
Yeah, and you can't even teach this stuff in the dental schools.
Oh no, I laugh when you say that because people say, "What? You've been in practice this long. You should go back to the dental school and be a teacher there." I said, "I wouldn't last one day."
Yeah.
If I started talking this stuff, they'd kick me out. Although I would say, I'm going to give New York Dental School did stop teaching about amalgams about maybe 10 years ago.
Okay.
And I was in the school doing my sleep residency there. And I asked, I said, what is the reason for that? Is it because we have better materials? He said, well, we do have better materials, but it's because we know mercury is toxic. I said, good for you. Well, why can't we spread that to all the dental schools? So I think at some point, there'll be dentists coming out and won't even know what amalgam is or how to place it. So that's a good thing.
And switching back to fluoride, wasn't fluoride a byproduct of another industry and then they decided to use it?
Yeah. So we know that it, costs millions of dollars to dispose of the fluoride from these industries. So with their mass intelligence decided, well, we could actually make money on this. So let's sell the fluoride to the government. Let's first convince the dentist and the ADA that it's good and prevents cavities. I mean, who wouldn't want that, right? So they dumped it in the water. And they did a study, I forget what year it was, it might have been even back in the 70s in Texas, where they showed that putting, I forget how many parts, so I get, correct me if I'm wrong, it was 2 to 4 parts per million or something like that. And they said it's toxic. And then they turned around, they buried the study and put like 10 parts per million. So it's like they're just deliberately poisoning people and selling it as a benefit to prevent cavities. And I'm not at all convinced. And I was shut down on a forum 20 years ago where I mentioned that fluoride was toxic. And one of the, I think he was a dentist, said, you didn't even graduate from dental school, did you? Yes, I did. And actually, I graduated with honors. I was the speaker at graduation. So, I wasn't not at the bottom of the class. I'm sorry that you're not open to that, but yeah, censorship has been going on for a long time.
Oh yeah. The dogma runs deeply.
Yeah.
For sure. And so people are going to have fluoride in their bodies because most of us, unlike Lauren and Renee, we did not grow up biohacking. I asked Lauren and Renee when I interviewed them, what was it like, having your dad as a dad? I mean, let's see, do you have you biohacking in the crib or when you were 3? And they said, well, we ate, some junk food like popsicles and things, but we ate, mostly healthy things. So how do people who were exposed to fluoride during their childhood before they learn this stuff, how did they get that out of their body?
Well, as you know, there's certainly poor detoxification pathways that our ancestors were very healthy in, whether it's poor methylation or genetically with the MTHFR and other SNP. So it's challenging. I mean, I believe that we need to detox on a regular basis.
Yeah.
I think we're getting exposed to so many things in addition to fluoride that I don't think, as I read, I think it was in the Washington Post, some physician wrote an article about why all this detoxification. That's what our liver is supposed to do. You're right. It's supposed to do that, but it's overloaded. So why are people so, toxic? Because you're getting bombarded. And I learned from another one of my mentors, Dr. Jerry Smith. He talked about physiologic adaptive range. So some have a very large physiological adaptive range and some have a very small one. And I think all of us it's getting smaller and smaller. And I'll use an example. My wife's aunt will be 101 this year. She still has root canals and mercury in her mouth. So, but that's an exception to the rule.
Right.
She worked for a dentist who didn't believe in the same things that I believe in. So when he passed away, I said, now that he's gone, why don't you let me get your mouth healthier? And she kind of was reluctant to do that. But I can't argue with her about that. I can't argue about her poor diet. She's 101. So
right.
When I'm 101, maybe I can have that conversation. But again, I said that, as we said earlier, we're talking about N equals 1. She's clearly an exception to the rule.
Right.
Because we look at the average age of mortality is actually going down, not up. So, and the only reason I think it's not lower than it is because people are being kept alive with pharmaceuticals.
Yeah, absolutely. And I've read that tamarind can be good for detoxing fluoride. Any thoughts on that?
I think it's great. I think we need to, again, understand bio-individuality. What might be good for someone else you may not have the same positive response. So,
right.
and if that's the case, don't give up. And if you don't have the response, don't say, well, that doesn't work. As you know, with social media, as soon as somebody tries something that doesn't work, they're right on there, downgrading it.
Yeah. Right.
So it's a confusing time for sure. Well, and social media has made it better and also somewhat worse because people are so confused. I even had a patient the other day that said, I'm hearing different things from other dentists than what you're telling me. I don't know which belief. I said, look, you have to put all the information together and decide what's best for you. Don't believe my truth. Don't believe their truth. You have to create your own truth, and you have to be your own health advocate. That's the bottom line. So
Right.
I don't want to certainly force you into my belief system. I'm just out here teaching something that's not taught by traditional dentistry so that people have a potential for an awareness that's not being certainly, let's say, promulgated throughout the industry. So thank goodness for social media. It's good and it's bad. So I mean,
Absolutely.
I don't know if you saw, there was a recent YouTube thing about the dangers of methylene blue and how it's, it's really harming people, and it's just like wrong information. So, but people will believe it depending on who the source is. If they acknowledge that person as an expert, then that's what they're going to believe. So
I did. So I take methylene blue, I cycle it, but I have found some data showing that, you want to test G6PD levels. And
right.
if those are off, because the renal dysfunction, that is a small subset of people, but if you're one of those people, it's 100% true for you, right? And then the other thing, I mean, this can segue us into airway, upper airway resistance syndrome, but HIF1, hypoxia inducible factor 1. Joel Green, the author of the Immunity Code, I don't know if you follow him, but he talks about methylene blue, and he's not opposed to it, but it can increase HIF1 levels.
Yeah. Yeah. So you got to know those exceptions instead of making a broad statement.
Right.
Good for everyone or it's bad for everyone. No, that's not true.
Right.
That's why I say you got to do your homework. You got to be your own advocate. So don't take the word just because someone's saying, "Oh, methylene blue is the greatest thing since sliced bread." It could be, but also could be harmful.
Right.
And if we talk about airway, that's another, I'd say, epidemic. When I first started treating mostly snoring, because we didn't have the technology to really look at airways. We didn't have cone beams. We didn't have home sleep studies. They had sleep centers, but they're few and far between. And every time I suspected someone had an issue, I would send them to the sleep center. And you know what? I never saw them again. They never sent them back. They just put them on CPAP, and that was it. So then with the introduction of certainly the CBCT, now we can look at structurally and anatomically these compromised airways. And going back when I first started, it was always someone, typically male, 50, 60 years old, overweight. Those were our primary candidates for treating sleep apnea. Now I see young women, thin women, teenagers, children with sleep apnea or sleep disturbed breathing or upper airway resistance. It is really an epidemic. We talk about epidemic. That's not one that's certainly taught on the mainstream media.
Right. Yeah. And normally I have it up here on my desk, but 6-foot tiger, 3-foot cage.
Yeah, I know Dr. Liao very well. We used to work together. I've done his training. I was actually one of the first ones to edit that book for him before it came out. He's doing a great job with educating the public. And this is information that goes back again to Weston Price. He talked about nutrition, but a lot of that had to do with really airways and, well, I'd say jaw development.
Maxillary width, right?
Yeah. So when he looked at different cultures, of course, around the world, they didn't talk about airway issues, but they were healthy. They didn't have cavities. They didn't have periodontal disease. They didn't have all the modern conveniences that we have. Probably, it actually would pull a twig off a tree, and that's how they would brush their teeth. And they had these amazing large jaw structures. So we really didn't have airway issues. And then what happened, and I'm a candidate of that, I mean, a victim, I should say, of that, having not been breastfed by my mom, being the third child, and then having 4 bicuspids extracted, and then put braces on and retract everything. There's a Dr. Haig who talks about extraction, retraction, regret syndrome. So everything was, pushed back. No one was thinking about airway. Right. So I'm one of those victims. Fortunately, I don't have sleep apnea, and I have obviously tested myself. But I do a lot of things to prevent that. Make sure I'm mouth taping, nasal breathing, using Batico breathing. So a lot of things that can help overcome that, being careful how my sleep position. But I was in the process of doing expansion with the Vivos appliance. I'm now going to switch over to the Homeo block. So even at almost 72 years old, you can still expand the arches. And I'm going to be a perfect example of that.
So let's talk about that because I interviewed Dalis DeAndrade. She's a dentist at Biohacks. She's Dr. Marcos DeAndrade, his wife, and she owns the Biodental Clinic. But she likes Vivos. But I know you like Homeo Block. So talk to us about the pros and cons.
Yeah, so I have experienced both. Number one, and I don't want to downgrade Vivos. I think they're doing a great job out there of getting the word out. I was one of the early adopters in Vivos. They got bought out by an equity firm, so they became more corporate. They immediately increased the lab fee for fabrication, which made it then, obviously, to pass that on to the patient made it almost very difficult. But what happened, I was at a sleep conference and I went into the exhibit hall to one of the labs and I said, by the way, is there anything compared to the DNA appliance, the Vivos? Well, they have to call it Vivos now because the FDA said you can't call it DNA, even though that's stood for daytime, nighttime appliance. They consider that because Dr. Singh was saying this epigenetic, and they, of course, came down on about that. So anyway, I asked this lab tech, I said, yeah, there's a thing called a Homeo block. That actually the inventor of that and Dr. Singh were partners at one time. And Dr. Singh went off and did the DNA appliance, and the Homeo block is still available. So I have worn both of those. And the DNA appliance I found for myself and my patients was very difficult to constantly adjust it properly. So as you expanded it, what I found is the springs on the appliance tended to rise up on the teeth. I don't have that problem with the Homeo block, but that's my personal experience. And I said, this is not me downgrading the Vivos appliance, because I think that's a great company and I think it's helping a lot of people. And I think that's the most important thing, but we're all going to have our personal likes and dislikes. So, and in my hands, I just find the Homeo block works better. So
Homeo Block works on the maxilla only, right? But then people will say the mandible follows the maxilla.
no, there is also Homeo block has a lower appliance.
Oh, they do.
Yeah, we are expanding both arches at the
Okay.
same time. I mean, because if you increase the palate and not the lower arch, you're going to have a pretty severe malocclusion.
Yeah.
And you got to be able to get that tongue in a forward position. So if you're doing myofunctional therapy as you are, or if you're doing a frenectomy, we got to make room for that tongue because the major obstruction causing obstructive sleep apnea is the tongue. Second is nasal passage. So obviously anatomically, as we lay back and sleep, we can see that tongue fall into the back of the throat. We also see elevated and expanded or enlarged soft palate, which is a reason for the night laser, the Photona instrument, to reduce that through non-ablative laser surgery. Just to clarify, non-ablative means doesn't cut, doesn't burn. Because as soon as you say laser, people think, oh, you mean like on Star Wars? Like you're going to cut the soft palate out? No, we're not.
No, not at all. And a lot of people, so when you expand them, I think people that I work with, they forget you're going to need braces at the end, right? Whether it's Invisalign, because you don't want gaps in the teeth. But from what I heard from the Pankey Institute, when you measure from 3 to 14, you want it to be 42 millimeters.
Correct.
They said, yeah.
Yeah,
and most people are what
it's interesting. We can do a very simple test, not very scientific. The width of a cotton roll that dentists use a lot, it's just about that size.
Okay.
Yeah.
Okay.
Now, I don't use that as the final determination. I use that through the process, see if they're getting closer, and then I'll use a Bowley gauge and actually make the physical measurement before we go on to phase 2.
What's the most narrow maxilla you've ever measured?
I mean, I see these V-shaped arches that can be, 20.
Wow.
Extremely narrow. I don't know how they're even breathing. And the thing that you need to understand is that when you have that V shape like that, it's not only affecting the posture of the tongue, it's also because the roof of the palate is connected to the septum. So then you have this pushing up into the nasal septum, and you'll actually see the septum is deviated or curved. And when you spread the palate out, you'll see that drop down. So there's not just tongue posture, but also nasal breathing improves.
Yeah, as another one of my colleagues says, the roof of the mouth is the floor of the sinuses. Don't
Yeah,
forget that.
absolutely. Yeah, we forget about, we get so locked into what our expertise is that because typically that's something for the ENT, but as dentists, we need to understand that. And it is really, we have as much of, I'd say, purpose and reason to treat these than maybe an ENT. Because when you think of what is the ENT's tool? Surgery, mostly, right?
Right.
We got to clean out those turbinates. We got to open up the nasal passage. We got to take out the tonsils. Got to take out the adenoids. Well, why don't we first, let's see, do some expansion. Let's look at food allergies, food intolerances. Let's get this child breathing through their nose, stop breathing through their mouth, and then reevaluate. Don't just jump to surgery right away as the conclusion to an answer to the problem.
Right. Yeah. I mean, surgeons typically, especially the residents, every case is a surgical case. Get out, everyone else, get out of the way. This is a surgical case. Get out of the way. I'm like, okay, have you done anything? Okay, how do you know it's a surgical case? And that I think I originally I was going to go to veterinary school. So in high school, I worked for an equine veterinary clinic. And Mississippi State has a program for advanced high school students where you do 2 years of undergrad and you go straight into vet school. So it shaves 2 years off. But I ended up not going because they were dropping like flies, having heart attacks in their early mid 40s. Because there's no emergency large animal clinics like there are for small animal clinics. So you're on call usually every other weekend and you're working 80-hour weeks, even when you've been doing it for 10 to 15 years, and then plus the call. And the pay is not as great as people think. But one of the surgeons I was working with, he said, always remember that you exhaust all conservative measures first before you go to surgery. And, human medicine, I think, and then same thing with, if a dog is sick, for example, you're going to say, oh, well, has he been exposed to any pesticides or any chemicals? Did he get into anything? They investigate those things, but environmental medicine was considered quackery up until like a year or two ago. Some people still consider it quackery.
Yeah.
What a novel idea. Your environment, what you breathe, could play a role in your health. I mean, you breathe, 12 to 16 times per minute, times 60 minutes in an hour, times, 24 hours in a day. So yeah, the air you breathe is like super important.
Yeah, you're right. Whether you're outside or inside your house or inside your workplace, it's extremely important. And I think that's been the explosion of, things like Air Doctor and Jasper and these other filtration systems. That what's more important than the air we breathe and the water we drink and the food we put in our mouth?
Yep. I got my Air Doctor running back over there. A colleague, I first started learning about mold and mycotoxins in 2009 when a colleague gave me Richie Shoemaker's book on mold warriors. And I have the quote unquote dreaded genotype. I work with a lot of people with mold toxicity. I don't test for the dreaded genotype anymore because, Dave Asprey has it. I have it. Lots of people have it. It's still very, very possible to get mycotoxins out. And all it did was freak people out, increase their sympathetic tone, and then cortisol spikes. And then we're, in a vicious cycle. But airway health, there's this from the book, but there's an image of a guy pushing a boulder uphill. And it says everything in your life is going to feel like you're pushing a boulder uphill until you fix your airway.
Absolutely. The amount of energy required to just get through the day. And I do educate my patients that, your problem's not only when you're in bed, it's throughout the day. Now, you have certain mechanobaroreceptors that can accommodate you while you're in a vertical position, but your airway is still compromised. And,
right.
So do you ever feel like you're breathing hard just going up a flight of stairs? They go, yeah, you got an airway issue. They go, well, that's not possible. I'm in shape. I work out. I run. So I said, well, just think what you could do if you could actually breathe the way you were meant to. So it's again, it's an epidemic and people aren't realizing. And of course, again, Tim, what's the answer? CPAP machine, right? Uh, the gold standard. And
Yeah.
I think the latest, or it's probably been a while since I look at statistics, about 35% of people who get a CPAP actually use them. And I'm not, again, downgrading. They are, for some people, are life saving. You know, if you have someone who has an AHI of 60, 70, severe sleep apnea, they're overweight, they need, I say, get on a CPAP machine right away. Okay. And then we can talk about what we can do from a dental perspective. But right now, we need to save your life. And then, you know, they lose some weight, they start to feel better, and they get tired of wearing the CPAP. Because what the CPAP does also, which we already talked about, it retracts the face. So it's putting traction on the facial muscles and the skeletal structure. And then, of course, you're increasing dry air into the back of the throat, which then causes irritation, inflammation of the soft palate. So then actually can make the problem worse. And then, of course, with all that said, what happens? They find these machines have mold in them. So they take them off the market.
Yep. So I was able to get my dad off of the CPAP by getting him the correct oral appliance. I didn't make it. I had a colleague make it. But, you know, obviously, if you're trying to force air down an airway and the tongue is slipping, you know, down the trachea or over the trachea, then that's not good. And so I was able to get my medical insurance to cover my oral appliance. But in order to do that, I had to go to the pulmonologist first. And he goes, "Yeah, you need a CPAP." I said, he didn't know what I did for a living. I said, "Listen, bro, I'm not doing a CPAP. Like, you probably get this over on most patients. You know, you're scaring them that they're going to die if they don't get a CPAP. I'm not doing a CPAP. Like, I'm not going through this with you. Just sign off and we'll call it a day." And he did. And, you know, I was telling you, I no longer have sleep apnea. Of course, I'm doing the myofunctional therapy and hoping to get, you know, better and better. I'm also doing the jaw exerciser. Are you familiar with that?
Yes. Yep.
Yeah.
Exercising the jaw muscles, it's important. You know, we just don't realize how much occurs in this part of the body. I mean, you got the brain here, you got the trigeminal nerve, the largest cranial nerve, which is innervating the upper arch, the lower arch, and then affects the entire central nervous system and, of course, the autonomic nervous system. We just take it for granted, right? That's why I am very excited, even after 45 years of doing the work we're doing as a dentist, because I think we can make huge changes in people's health. Now, we don't obviously have the answers to everything, and we have to work with integrated practitioners. We have to collaborate, you know, whether it's doing, you know, functional medicine, chiropractic, acupuncture. I mean, all those things have a major impact. Unfortunately, and I'm a little biased, is that quite often the mouth is overlooked. And I tell patients when I first see them, I said, you know, think about this for a second. What part of your body has had any intervention? And majority of people say, well, you know, I don't know, I had a knee replacement. I said, no, think a little more closely. Like, oh, my mouth. So you've had braces, maybe you had your jaw broken, maybe you had root canals, teeth extracted, fillings. I mean, all this is an attempt to create a healthy mouth, and many times does affect the systemic health that we're not, as dentists, trained to look at. So here we are in good faith trying to help people, for sure, because the goal in today's world in dentistry is to save teeth. Now, in my parents or even grandparents, it was, if you had a problem, you just took them out. And you can look at some of the, you know, I know it's anecdotal, but people had severe health issues and had periodontal disease and took all their teeth out, and suddenly their health changed, like for the better. You don't hear about that, but so now we're going to do everything we can to save the tooth, regardless of how it may affect the patient's overall health, and that's ludicrous. I think, and I had a patient this week. I said, you know what, the dental work I see here, mechanically, it's perfect. The fillings look great. The root canals look great, but we're not looking at the systemic effect of that. And I said, these root canals will harbor bacteria. There's no way for the body. They're like, well, can't I just take an antibiotic? No, because you have severed off the bloodstream to that tooth. There's no way to get an antibiotic even around that. And even if you did, if you killed everything around it, and Weston Price showed that, he actually extracted the teeth, steam autoclaved, and so killed everything. All of my reimplanted, and it wasn't, only a matter of time before, microbes grew back in there because you have an anaerobic environment. So
Yeah.
understanding that is a little bit challenging because we're not really looking at physiology, biochemistry, biology as dentists. I hate to say it, we're just really good mechanics.
Drill and fill, right?
Yeah, that's it. So even though the first 2 years were very similar to medical school, we took anatomy, physiology, biochemistry, microbiology, and then going to the third year, it's all about, like you just said, drill and fill. Let's
Yeah.
do, we got graded based on how good the filling looked. I mean, we spent so much time carving the perfect anatomy in these amalgams and then polishing them to make them shiny. Little did we know we're sitting there poisoning ourselves and our patients.
Yeah. And to go piggyback on something else you said about the trigeminal nerve, right? So it feeds into the same nucleus caudalis is the vagus nerve. So
Right.
it affects vagal tone. So it's your airway, it's the autonomic nervous system, which controls everything, right?
Yeah, you wonder why people have such anxiety issues. Everyone's in such a sympathetic tone, fight or flight all day long. Then, when the day's over and we go to bed, we should at least at that time go into a parasympathetic, but that's not happening because the airway is compromised.
Yeah, I know it's crazy. And remind me or tell me if I'm wrong, but the brain and the teeth are derived from the same embryological tissue, correct?
Correct. Yep. So you have a direct connection, and besides what we just talked about, the trigeminal nerve, this is the largest cranial nerve, innervates what we do every day. So when you're getting an injection, say on an upper tooth, you're actually dealing with the second division of the trigeminal nerve, and then of course with the mandible, lower jaw, it's the third division of the trigeminal nerve. So we're actually affecting that nerve on a regular basis, which is also obviously you have to have some delicate way to provide anesthesia because we do not want to cause permanent damage to that nerve, but it can happen. So you got to be extremely careful. You got to make sure that you're not injecting into the nerve or the vascular, even the vascular supply. And patients sometimes say, I'm allergic to anesthetic. I said, what do you mean? He says, well, the last time I got it, my heart started palpating. I said, that's not an allergy. The dentist unfortunately got the anesthetic too close to the vascular system, got in your bloodstream. Epinephrine is a vasoconstrictor, and that's going to cause palpitation. I said, it went away, right? I said, yes, but it scared me. So there's another myth. People think, I can't get anesthesia. You can, but we have to be super careful as dentists. So it's a profession that requires definitely a different level of skill. That's the mechanical part. But what about, how we're affecting? Are we improving the person's overall health, or could we be adding to their burden? And I think that's where we can play an important role. And you know what, Tim, and you know this well, this is not new stuff.
Right.
I mean, my mentors were doing and preaching this in the 70s. Of course, Weston Price in the 1940s. So, and even G.V. Black, who was the father of modern dentistry in the early 1900s, talked about cavitation, these bone cavitations. And then that suddenly disappeared from the curriculum at the dental school and even in the oral pathology books. Suddenly the chapter on cavitation disappeared. So it's not like this great new evolution, but in some sense it is because now the word's getting out. And I think because of podcasts like yours and social media, people are becoming more aware, people are educating themselves, and we get patients all the time, like the stories I hear from the dentist they went to, and then, of course they think I'm a quack because I'm patient this week said the dentist that I used to go to said that you're just teaching quackery and that you just want my money. And like, I don't want your money. I just want to help you. So, and I'm here to educate. If you want to get your root canal out, I'm here to help you, and I'll do it correctly, the right way, so you don't end up with a cavitation. You want to keep the tooth? That's fine. Let's look at some other things that might help you to overcome potential systemic issues. Whether we inject ozone in there, let's see. I mean, when a dentist does a root canal, are they checking for C-reactive protein or other inflammatory cytokines? No. Are they doing a DNA connection test to see what bacteria or other microorganisms are around that root canal after it's completed? No, they're not. And I had this conversation with the dentist. I'm not going to mention her name, but she's professing to be doing a biological root canal, which I consider not possible. So, and I asked her at a conference, are you testing? And she said, well, we don't test them because the test is too expensive. And I said, well, why don't you let the patient make that decision if it's too expensive? She didn't really have an answer for that. But to me, that's a kind of an oxymoron.
Yeah.
Yeah, a biological root canal. That, I mean, you could say I'm doing a root canal different than the standard way. And I'll be honest with you, if I was going to have a root canal, which obviously would never happen, I would do it that fashion. They're using ozone and using lasers. That's definitely better than the traditional root canal therapy. So, but it still doesn't accommodate. And we're not, again, addressing biological identity of each patient. Like I said, my wife's aunt, she's got a root canal. She's living 101. How many other people are dealing with that? That is a problem, especially now. What I'm seeing over and over again, patients coming in, tick bites, and now they have Lyme and then mold on top of that, and they just can't get better. How much of the mouth is contributing in terms of keeping that person from healing, even with all the therapies that they're doing? So.
Yeah, absolutely. Talk to us about the curve of Spree, the curve at the back.
Yeah, so there is a normal anatomical and physiological position of how the upper and lower teeth meet. So they should not be flat on flat. It's not like, say, George Washington's teeth, where they, and by the way, they were not wooden. They were made out of ivory tusk. But when he clapped together, they sound like wood. So your teeth should not be flat. The teeth themselves have a curvature or anatomy to it. And then there's a certain curvature, as you just mentioned, the curve of Spree. And that is how the teeth should come together. Now, when we talk about function or physiology, there are people who are missing teeth, teeth are shifted, and somehow through adaptation, they're still able to function. So, and then there's on the other end of the spectrum, we'll have a patient who has a slight discrepancy, maybe in that curvature or how the teeth meet, and they're having all kinds of problems. They may have neck pain, they have shoulder pain, hip pain, because we know the cranial system, is affected and affecting the entire body. And what has a major effect on the cranial system is the bite. So how your teeth come together, the maxilla is part of the cranial system because it's connected to the temporal bone, of course, the sphenoid bone and occipital, parietal, all that. And that goes right down the spine and affects the cerebral spinal fluid. So how people are biting. So just a small discrepancy in the bite or the curve could affect them physiologically. Why does that affect some people, not others? It's still, what we're talking about, Tim, the physiological adaptive brain. Some can adapt to it and some can't. So there's no perfect. And I get patients that, my bite's just not perfect. And I'm like, so what's going on? It looks fairly normal. Yeah, but I can't tolerate it. I just had this filling done. So we got to then accommodate that and adjust it so that we can have them back into an adaptive range. And we use a technology called a T-scan where we can actually measure the forces of occlusion. So from one side to the other, is it symmetrical? It should be 50%. And then each, like the molar has a greater percentage of force than, say, the anterior teeth, but sometimes that's way off. And that's how we get away from the old tap, tap, tap with the blue paper, which is really archaic. So we need technology like the T-scan to really zero in, like, where's the problem? And we can see it because we might see, for example, a molar would typically have anywhere from 10 to 13% of the total force. We might see 27%. And it may not show up on the blue paper. So that allows us to get back into that, I'd say, adaptive range.
And that's called a T-scan?
T-scan, yeah. There's a couple other products out there. The one we have is called T-scan. I think there's some others that have come out since then. But it's basically measuring occlusal forces. Like how hard are your teeth hitting? And are they hitting each? So I see some patients that are hitting one side is 30% of the force and the other side is 70%. I mean, that's obviously quite a discrepancy. I just had a patient this week who was, they were 49.9 on one side, 51.1 on the other. I'm like, that's good. That's probably as close as we're going to get.
Yeah.
So, but I wouldn't know that looking at blue paper.
Right. Yeah, I've
Paper.
had the blue paper thing done, and I was like, I don't know how accurate this is, but okay, I'll go with it.
I mean, I'm not discrediting it. I mean, it's a place to start. And if you have someone who has a fairly normal occlusion, has a normal curve of spray, doesn't have any TMJ issues, and you do a single filling, you're going to check the bite. You're probably going to be able to get pretty darn accurate with that blue paper, because sometimes it's just a minor adjustment. But when you're doing TMJ issues or other neuromuscular issues, you got to know what these forces are, and you got to understand the cranial sacral system too. And I got trained with John Upledger Institute, so we used to have this discussion, like if you do the cranial sacral adjustment, the teeth will automatically adjust. And I said, no, I don't believe that. Teeth are hard structures. I think you got to work them both together. So when a patient are coming in and I say, can you make me a bite splint? I said, well, first of all, if you need a bite splint, we're going to do a sleep study. We want to know if you're clenching or grinding, or what we call bruxism, is it related to a sleep disordered breathing? So let's first determine that. And there's very few sleep studies that test for bruxism, but the one we have, the Knox 3, does test for that. Because if they're bruxing because their oxygen levels are going down throughout the night, their SpO2, we need to address that, not the bruxism. So I spent many years making splint, and you know what happened like 2 years later, Tim? I made them a new splint.
Mm-hmm.
They ground through it.
Yeah.
No one's getting to the root cause.
And what do you do for people? Because, growing up, my dentist never mentioned it. I mean, he's like, yeah, you're grinding, but he didn't say, oh, let's do a sleep study. I mean, it was never mentioned. So for people who you've worked on their airway, but their occlusion is not good, do you build them up?
I typically will, I said, first address if there's a sleep issue, because in that case, we may use, like the Devos or the Homeo block. Let's get that first. And then once that's done, then we can deal with the occlusion. And that might be, some kind of appliance where we're adjusting. Let's say, and I'll take a step back. Let's say they don't have a sleep issue, but they have a TMJ issue and they have a bite issue. I'm not going to go in there arbitrarily and start grinding teeth down. I'm going to put I call this splint a fake bite. I said, I can adjust that piece of plastic over and over again without ever touching your teeth. So there's a term called occlusal equilibration, which I think really has been misused. It meant to be for minor adjustments. But when you start adjusting someone's bite, right to left, right to left, right to left. Oh, it's hitting harder here. Okay, let's adjust that. Now it's hitting harder over here. But they're like this. Their spine is off, their craniosacral system's off, and they're not swallowing properly. Poor tongue posture, and we're trying to adjust the bite when everything around it is off. So I use the splint as an arbitrary bite, and let's now, whether we're working with chiropractor, osteopath, massage therapist, whatever, let's get the whole body aligned. And then once that's done, then we can look at things like Invisalign or braces, now to bring the teeth in harmony with the skull and the cranial system, rather than the other way around. And how many orthodontists are even looking at that? Their whole goal is, let's get pretty looking teeth. Let's make sure these teeth are nice and straight and they smile. They're not looking and they're retracting the teeth. They're creating more problems.
And don't forget the doctors of physical therapy like myself. That was my formal training. But I did, cervical spine manipulation, active release technique. We even learned an active release technique for, the muscles around the face, and even one inside the mouth to release it. And then I have some colleagues, I don't have a physical office anymore, so I don't do this, but they do dry needling in the muscles of the face.
Yeah.
And so I was talking to Stephanie about that as, one potential adjunctive therapy to what you guys do.
Yes, I think, and I would recommend to your listeners to find someone like you who does what you do. And if there's any dentists listening, they definitely should be working with these practitioners, because I'll say, even though I was certified from the Upledger Institute as a craniosacral therapist, I don't really do that. I do some intraoral stuff, like I'll release the lateral pterygoid. I may do a little manipulation of the maxilla, but you need to see someone who does this on a regular basis, you know. And then
Yeah.
obviously, my license does not allow me to put my hand on patient's sacrum, so I'm not going to do that.
Yeah, I know, but it amazes me how political it is because I saw a Klinghardt trained orthodontist, but he was not hyper focused on the teeth. Like he would do the autonomic nervous system, the ART testing, not active release technique, but the autonomic response testing. And he was big on that and talking about the trigeminal nerve. I don't think he did much with the airway, but he was very big into the autonomic nervous system. And so he was ahead of his time. He's retired now, as far as I know. I think he's still alive. But yeah, I don't. He said, don't tell anyone that I'm doing anything, below the neck. And I was like, I mean, it doesn't make sense. You took anatomy, you took physiology. I mean, you either know it or you don't.
Yeah.
As long
So
as you're not
with
doing
that
like
said,
spinal surgery.
yeah, with that said, Tim, in at least in Maryland, you're not allowed to do anything below C3 as a dentist. So heaven forbid I do, any kind of craniosacral adjustment that might affect you below C3, or if we're doing trigger point injections, right, into the trapezius, all those things. Like our hands are tied, and it's unfortunate. I'm not recommending people do things they're not certified in. Like I don't want to do craniosacral therapy on my patients even though I'm certified. I want somebody who does this every day, day in and day out. They are the experts. So, but I think we should all understand the work that you did, and with chiropractors, osteopaths, we need to understand that as dentists and figure out how to work with our patients and help them. It's, we can't solve all these problems because it's not, the teeth are connected to the jaw is connected to the skull, it's connected to the neck. So
Yeah. And so I know Lauren and Renee said they've been trying to get you to retire for a while, but it looks like you're ramping up instead of ramping down. You just opened a biohacking center, correct?
yes, this has been also a passion of mine for a long time. And my girls, they joke about it, calling me the OG, but, some of these things we didn't call them biohacking. I think their first experience was, walking into our kitchen. I had an ear candle, trying to pull the wax out of my ear. And I'm like, you're crazy, Dad, And then, in the very early 90s, I had a, red and infrared light, from Dr. Lytle. And on the device, it actually said on the back, you may be familiar with this, it said for equine use or animal use only. And I thought, and here we are, 30 years later, everyone's got a red light.
Yeah.
We're using it like crazy. And I said, we obviously didn't call it photobiomodulation. We actually called it low-level therapy, low-level laser therapy. And then Dr. Lytle, who actually was promoting that and selling that, I think lost his license because of it.
Wow.
So that was kind of my early biohacking. And then I bought one of the early PEMF mat. So it was very antiquated. It looked like something built in someone's garage. And here we are today. They got PEMF everywhere, right?
Yeah.
So I'm trying to think then, we had infrared. And now, present day, of course, I have infrared.
Biocharger.
Got a biocharger, got a Rasha, got cold plunge. So we have all of
What's
that.
the Rasha?
The Rasha is, I would say, it's energy coherence, higher consciousness, and similar. And from Dr. Jerry Eugenio Rivera, who invented it, if he compared that to the biocharger, he said this is base 12 and this is base 10. Biocharger is base 10. So he's certainly promoted as a higher elevated piece of equipment, and it really deals more with higher consciousness than the physical. Of course, we have PMF. We have lots of red lights. We have a red light bed, hyperbaric oxygen, nano V, hydrogen gas, both inhaling and also ingesting. This is my passion. So it's a great connection because the things I do as a dentist, like how can I help these patients heal? How can I help them detox? And so the opportunity came to open the center in the same professional park where I am. So patients can walk right over, do the hyperbaric, do the red light. And it's kind of as you said, I'm my wife's what doesn't look like you're ramping down too much.
Yeah,
So, but you know, also Tim, you're very similar. How do you slow down? How do you stop doing this? You know, you're helping people. Um,
right.
and, you know, I think they used to say, you know, you think you're not replaceable. You know, there's other dentists who could replace you. I said, there's not many. I'm not
Yeah,
bragging. I'm
exactly.
just saying this has taken 45 years to get to this level. And you
Right.
can't take a dentist right out of school and hire them and expect them to do this.
Well,
So,
yeah, first of all, I think it requires a certain level of emotional maturity, because you have to admit, okay, a lot of stuff I learned was incorrect. It was dogma, more indoctrination than education, right? Like, take, for example, the airway, deep cervical stabilization. A lot of doctors of physical therapy will have you do chin tucks to strengthen the deep cervical flexors. But if you have a small airway, that's a really bad idea. You have to understand this stuff. You can't just say, oh, if you have this, you do this. If you have that, you do that. I'm like, no, it doesn't work that way. So where can people, because I've referred a few people to you, referred two this week. Um,
thank
so
you.
where can people find you if they want to seek you out?
The website is juliandentist.com. That's the website. Of course, you can find me, Eugene Sambataro, on Instagram. Um, yeah, so we are in the process of consolidating 4 different websites, but all be consolidated into the Julian Dentist. We used to have one on ceramic implants, one on toxic-free dentistry, and one on sleep. So we're just consolidating all into one. So we're pretty easy to find. I appreciate any referrals. Thank you. And I want to thank again for this opportunity. I love having these conversations with like-minded people. I'm sorry we didn't connect sooner.
Oh, it's
My
fine.
fault. So it's been great.
Yeah, and how did Lauren's surgery go? I saw her a post commented yesterday. She had, the surgical cap on. I said, of course it's pink. I would expect nothing less.
She was so she's working with Dr. Pompa, who's promoting, a lot of holistic dentistry and talking about cavitation. So she's talking to her clients about that. And I said, Lauren, what would make a lot of sense for you to actually see what one of these surgeries are. So she came in as a surgical assistant and did some videotaping. It was great. It was a great experience for her because now she knows what it actually involves, experiencing from start to finish. So I think it was a great experience for her. And now she can actually have, a verbal, educated conversation about it. And I think
Yeah.
that's always important, not to just talk about it, to really, really actually experience that process of what we do every day when we treat these cavitations.
Yeah, absolutely. Well, keep up the great work. Thanks for what you're doing, and I'll continue to refer people your way.
Thank you, Tim. Thanks for your work and good luck with your treatment, your myofunctional therapy. I'm glad you were able to connect with Stephanie. That's awesome.
All right. I'll see you later, Gene. Take care.
All right. You take care. Have a great weekend.
You too. Bye bye.